Hi, everyone. Good evening. And welcome to all of you expectant and new parents and to everybody else who has joined us tonight. Thank you so much for logging on and being here. This has proven to be a very interesting topic to many, and we're delighted with the response and the turnout. Before we begin, I'd like to start off by extending a heartfelt thanks to our generous presenting sponsor for this evening, Bank of Montreal Financial Group. Your continued support during these difficult times is greatly appreciated by the entire community, and I thank you on behalf of the community. My name is Sarah Zagdansky, and together with my good friend Leonard Abramsky, I am the co-chair of this year's UJA annual campaign, which has now become the Emergency Campaign for Community Resilience. I'm pleased to welcome you all here to this webinar as part of our Now You Know series. And tonight it's entitled, What to Expect When You're Expecting During the COVID Pandemic. And I can assure you that you weren't expecting a pandemic during your pregnancy, and we weren't expecting a pandemic to hit us now. This has changed everything about the way we are living. There isn't anyone who hasn't been affected by this, whether financially, socially, mentally, or physically. No matter who we are or what we were doing only 7 or 8 weeks ago, we are all experiencing the same emotions and struggling with a new and unfamiliar sense of vulnerability. And I imagine that pregnancy and parenthood adds another dimension to that. But it is our beloved Jewish community that has been deeply impacted by the COVID-19 as well. Our Jewish community is in crisis, and it's a painful thing to see. People can't put food on their tables. Seniors and Holocaust survivors are isolated. Domestic abuse rates are rising with increased financial pressures and the needing to shelter in together. There has been a spike in people suffering from addiction and mental health challenges. Professionals who were once donors are newly vulnerable. Jobs have been lost. Businesses are suffering. Our core institutions of Jewish living, such as the day schools, the JCCs, and Jewish camping, are at risk of disappearing. The pandemic fallout is broad and has threatened the very fabric and foundation of our community. As a result, since the outbreak, there has been an unprecedented request for assistance from our community's social service agencies, our mental health resources, and our free loan funds. They are simply unable to keep up with the demands unless we step in by helping to support UJA. UJA is the only organization in Toronto that is uniquely positioned to address these dire needs the community is now facing. As our communal guardian, UJA, through its network of partner agencies, is responsible for protecting and providing for our most vulnerable and preserving the essential institutions of Jewish life that make our Toronto community one of the strongest and most highly respected in the diaspora. I've been so proud to see how UJA has managed to mobilize resources, suppliers, volunteers, and donors so swiftly to address and respond to the immediate and urgent needs of basic daily living for our most vulnerable, such as food, housing, rental assistance, and free loans. They have truly risen to the challenge with great skill and professionalism and compassion, and it's really comforting for all of us to know that we have such an organization that is there for us when we need it. Today is Giving Tuesday, an international day of action and philanthropy. What a perfect time and a perfect day to do a mitzvah and to honor your family and your family's future with a contribution to UJA. Your generosity will provide necessary funds and resources for those who need our support, especially during this challenging times. What we do today with this crisis and how we respond will define what our Jewish community will look like in the future. So now is the time for us to come together with our Jewish values of compassion, a sense of mutual responsibility, and tikkun olam, and to give back in response to the crisis that has rapidly befallen our community. We must do whatever we can to assist the renewal and recovery of our community and to ensure that our collective Jewish future, the one where we want our kids to be raised and to enjoy, remains vital and viable and emerges even stronger after we overcome this crisis. I want you to know that each and every donation to UJA counts, and I thank you so much for your consideration and support. I also want to remind you that if any of you are in need of support or assistance, UJA is here for you. Please don't hesitate to reach out to us. We understand the challenges and we care. If you need to reach us, if you'd like to make a donation, you will see in the chat box that there is a link for Jewish Toronto, and please don't hesitate to reach out to us. So may we always show compassion and be a light unto one another and a blessing. And I wish all of you who are expecting B'Shah Tova and every blessing for a safe and easy delivery and good health to you and your family on your parenting journey. Now it is my pleasure to introduce Dr. Tali Vogler. Tali is the staff family physician and chair of the family practice obstetrics team at St. Michael's Hospital in Toronto and is the founder of the Pandemic Pregnancy Guide. Tali, on to you. Thank you.
Thanks so much. Are you okay? So thanks for the introduction. So I'm a family doctor with special training in low-risk obstetrics and pediatrics, and you're correct, I'm currently the chair of the Family Medicine Obstetrics program at St. Michael's Hospital. And when COVID-19 surfaced, or really on March 11th when it was declared a pandemic, the first thought I had was, how is this going to impact my patients? Primarily because I see so many pregnant patients and their babies and families as they grow in my practice. And that's one of the reasons why we created an interim prenatal schedule to sort of guide clinicians here in Toronto, Canada, how to do prenatal visits in a safe way, as well as how to care for babies in a safe way during COVID-19. And we know that expecting parents feel anxious at the best of times, especially first-time parents. And now with COVID-19 and all the uncertainty that comes with it, it's understandable that there's a heightened level of anxiety right now, and we see it and we hear it with fewer in-person prenatal visits, cancellation of in-person prenatal classes and breastfeeding classes, and the limitations to support people in labor as well as postpartum. There's a lot of uncertainty and a lot of anxiety. And so this is one of the reasons why myself and a few other physicians at St. Michael's Hospital created this Pandemic Pregnancy Guide, which is a virtual platform on Instagram. And really the focus was to provide reliable medical information and to form a sense of virtual community. And I think this is exactly what we're trying to do this evening with everyone here. Trying to form a sense of community within our own Jewish community that exists. And we have a really, really fantastic panel that I'm very excited to introduce. We have Dr. Barrett from Sunnybrook Hospital, Dr. Spitzer from Mount Sinai Hospital, as well as Rifki Meldung, who is a registered midwife. So I'm gonna ask our panel if we can just each go around and just introduce ourselves and sort of what brought us here. And I'll start with Dr. Barrett if he can introduce himself.
Sure. Thank you, Tali, and thank you for the UJ for inviting me this evening. So I am a maternal fetal medicine specialist, or colloquially called a high-risk specialist. I work at, excuse me, Sunnybrook Hospital, and I'm a professor at the U of T. So my experience, like Tali, is also from a hospital base, but very different from the community aspect. It was really on two fronts, really. The one as a high-risk center and a major COVID center, preparing for the pandemic and what that might or might not mean in the days where we really had no clue what was facing us. And the second is because of a role that I have, I guess, in a network. I'm the head of something called the Southern Ontario Obstetric Network, which is a network of the 18 or 19 largest hospitals in our area, to coordinate and to try and make sense of all the different guidelines of care that are circulating. And then was called upon by something called the Provincial Council for Maternal and Child Health, which is a provincial organization which directs mothers and child's health in the province by the Ministry of Health to try and make some provincial task force guidelines. So we could have some standardization of the recommendations to moms and to caregivers in this very new disease, in a very changing environment where facts and knowledge change every day. And so that's been my background so far.
Thank you. Dr. Spitzer, if you can give a little introduction, thanks.
Thank you. So I'm a general obstetrician and gynecologist. That means I do, sort of full obstetrical care, sort of mostly low risk, although as we say sometimes in obstetrics, a low risk pregnancy is only when you look back on it. And I do general gynecology as well. I do some part-time pediatric and adolescent gynecology at sick kids, and I direct programs and fellowship program at our university in global women's health and equity. And what that means in short is that I have interests in particular in underserved populations, both locally, immigrants and refugees, our adolescents and adolescent care program at sick kids, and also with international populations where we work as well, as different as that has become in the past weeks also. And so I think when Sarah was speaking earlier a little bit about, some of the challenges that people are facing right now, I worry about all of my patients, but I for sure worry in particular about those with less resources and who live to begin with at the margins in society, for whom staying home may not be safe, or who are already facing economic challenges, for whom these past weeks are, sort of potentially even more devastating and challenging. And so those are some of the patient communities that I'm particularly responsible for and particularly concerned about at this time. And we've been working with an amazing group of trainees through our program also, who've been working on advocacy initiatives and care initiatives for those patient populations.
Great, thank you. And Rifki Meldung, if you can introduce yourself, that would be great.
Thanks, Tally. So I'm Rifki Meldung. I'm a registered midwife and a co-founder of Uptown Midwives and Family Wellness. And I have privileges and do deliveries out of North York General Hospital. And for us, we're dealing with COVID both in the community aspect and in the hospital aspect. So we are dealing with multiple guidelines from multiple sources, including our association, our college, our hospital, the SOGC. Dr. Barrett mentioned PCMCH, so PCMCH as well. So that's really what we are kind of trying to navigate and deal with.
Great, wonderful. So this is the way it's going to go. We've had lots of questions come in, and it's not surprising. There's many questions that are coming up. I see it all the time with my pregnant patients, and there's many uncertainties and many unknowns. So we're not surprised that many questions have come in. And so what we're going to do is essentially a rapid fire question and answer. We're going to try to go through as many questions as possible. Obviously, we can't go through all of them. We only have 50 minutes together, but we're really going to try to address some of the most common concerns that we've encountered and that we've received from our audience this evening. So I'm going to actually just start and jump right in, if that's okay. So the first question I'm going to direct to Dr. Barrett. So the first question was, I'm a periodontist and I'm 25 weeks pregnant with baby number 2, and I have to go see patients for emergencies, which are mostly surgical procedure. And I typically wear an N95 mask covered by a level 1 mask and a gown, a surgical cap, and sterile gloves. What kind of precautions do you recommend to protect mom and baby, especially mom if they need to go into practice in an essential healthcare context?
Thanks for that question. It's a question that's been the focus of attention of many of us in the front line, caring for people who are COVID positive and general patients. So the thing I think to understand is that this virus is spread by droplet virus infection. What does that mean? It means it's carried in the droplets that we produce when we talk, when we laugh, when we sneeze, and is spread that way, usually up by those droplets going into our mucous membranes, our mouth, our nose, our ears, or most commonly from our hands when we touch our faces. And it's interesting when we're on these Zoom calls and we actually realize how many times we touch our faces. We do it a lot and you can't help it. And that's why the media have been so focusing on washing their hands, because a lot of these droplets will spread onto surfaces that we touch all the time. Now, your question particularly about you're providing surgical surface and a close quarters to someone. You are certainly very well protected. In fact, probably overprotected because you're wearing what's called an N95 mask. Now, those are those masks that you've seen around people, the white ones with the yellow straps perhaps tight over the face. They are in very scarce supply in the healthcare system, and it's the PPE that is most most prized by the people who give direct care to patients with COVID in ICUs or in anesthesia situations. That's because in that situation, the virus can become what we call aerolized, which means it changes its character from being primarily droplet spread to something called aerolized spread. That's when you need 95. At Sunnybrook, we are going through 6,000 of those masks per week. And at the worst of the beginning, before we got our supply, we only had 2 weeks left supply. Without those supplies, the people in the front line, the ICU people, the anesthesia, the emerge, would not be protected. For most of us, we don't need that mask. We only need a droplet protected mask, which is a completely different grade mask. It's a drop. I usually have one sitting here because I wear it at home all the time. So when I'm closer than sort of 6 feet to my family. So that's the droplet mask. That is sufficient for protecting your question. Will probably be sufficient for protecting you, because you don't probably, as a dental surgeon, I'm not sure, but don't have an aerolizing procedure, which is just intubation. Intubation is the procedure which does that. So for most people, droplet protection, wearing this mask would be sufficient to protect anybody from this virus, which is why now at most hospitals, at our hospital, every healthcare provider wears one of these masks 24/7, and also patients are given this mask to try and reduce the spread, which it probably will do quite successfully.
Okay, great, good. Okay. Next question is one of the most common questions, and that's in terms of the risks of COVID-19 for pregnant moms. And then the next part of that, obviously, is to the developing fetus. So I'll throw it out there to our panel in terms of what is really the most up-to-date evidence if a pregnant mom were to contract COVID-19, and what are the health risks to the pregnant mom?
I can take that if you want. So what we know about this virus, and we know a lot, but not everything. And what we know is that in pregnancy, this virus is different to many of the other respiratory viruses, which are more risky for pregnant moms, because in pregnancy, your immune system, pregnant mom's immune system is altered. And so traditionally, pregnant moms are more susceptible to things like the flu or SARS or many of the diseases. For some reason, and very fortunately, and we don't know why, pregnant moms are not more susceptible to becoming sick from COVID-19. So in fact, there might be some evidence that they're less likely to be affected. From the data from China, there were less pregnant moms affected than they should have been, perhaps because more pregnant moms are more careful about social distancing, etc. But they don't seem to get sick. That's not to say you can't get sick. You can get sick just like anybody else can get sick, and serious disease is probably in about 5 to 8% of people. But pregnant moms are not more susceptible, which is good news. The second thing which is good news is that it doesn't seem to cross to the baby in any significant extent. There's a huge debate in the literature of whether it crosses at all. That's called vertical transmission. There are cases sporadic of vertical transmission. But even if it does, which we experts are still in controversy, it does not seem to affect the baby. Now, if a pregnant mom gets sick, and if a pregnant mom gets sick from anything, then there are complications that can arise because the mom is sick, and there have been unfortunate circumstances. So I think what we have to say for pregnancy generally, we should be reassured as much as we can be but we also have to be mindful that this disease can make somebody who is very sick quite quickly, and in which case it can certainly affect a pregnant mom and her baby because of that.
And I would just add to that, and based on the previous question a little bit also, that the Society of OBGYNs has been clear that to the best of the information that we have so far, being pregnant and working in a healthcare environment is not a reason to be off work at this point in time, based on the knowledge that we have, as Dr. Barrett was saying.
And the other thing is also we're actively collecting that information, right? So we have registries, international registries, and in Ontario as well, that we're actively collecting all the information. because, you know, our evidence is evolving as time goes on, but the evidence so far has been quite reassuring from, at least from China as well, and from the United States. So that's great. And a subsequent question to that along the same lines is, what about breastfeeding? There's been concerns, if I am COVID positive, can I breastfeed? Is there any evidence of the virus in the breast milk?
I'll take that one. It's a breastfeeding question. So what our association and college and SOGC is saying is that women can breastfeed if they use appropriate precautions. So there hasn't been any evidence so far in finding the virus in breast milk. So the recommendation we are telling clients is to wash their hands carefully before touching the baby, to wear a face mask, and breastfeed the baby. And that is what our clients have been doing, the ones who needed to.
Okay, great. Any other comments about that in terms of breastfeeding? Agreed. Okay, so what is a pregnant mom supposed to do if they feel like they might have symptoms of coronavirus? Who should they go to? Who should they call? What should they do?
I can try to answer that one. I think that the most important thing is to first and foremost, I mean, so long as they are well and not perceiving themselves, for example, to need emergency care from the perspective of being short of breath or in distress at home, I would say reach out and phone. I would phone your obstetrical care provider or your local hospital. What we would usually then instruct them to do is proceed for testing. I will put it out there that I know that we're hearing a lot about testing, capacity for testing, etc. Not all testing centers are prioritizing pregnant women at this point in time. I'm not going to say that I know all that may be, but for example, from Mount Sinai, we would be encouraging people to go to the testing center at Women's College Hospital, where pregnant patients are being prioritized, just as an example, and where certainly being pregnant with symptoms of COVID-19 would get you tested. Women's College does have a phone line that you can call first and be fast-tracked, or you can show up in person. And so again, if people aren't in, and they'll be assessed at that time, both on the phone or in person, as to whether their symptoms merit admission. But if they are doing well, they'll be given good advice about self-isolating for family, how to do that safely in your own home so that you don't infect other people, and what to do. As obstetrical care providers, we are all making appropriate arrangements in our hospitals and between ourselves as to how to care for pregnant patients who have COVID-19, whether that's sometimes less visits in person and or some virtual visits, or some visits in a very safe and contained environment where appropriate cleaning can be done afterwards. So the more somebody can reach out ahead of time so that we're aware, get that testing done, get that confirmation, and make those arrangements. Somebody is considered to have COVID-19 until they're 14 days after the development of symptoms, and at least 48 hours without symptoms. And so if somebody, for example, is reasonably well, we can, sort of follow up with them virtually at home, maintain care. Depends where they are in their pregnancy as well, in terms of gestational age and how often they need to come in or what other complications they may have. But we would try our best to care for them in the home environment to the extent that's possible, or make appropriate arrangements when they need to come in.
Excellent. And I think there's this misconception that I've seen in the general public that perhaps obstetrics providers wouldn't see someone who's COVID positive or can't deliver in hospital if they're COVID positive. And that's truly a misconception. Of course we will see you. We have everything in place to see patients who are COVID positive in a safe way. And so I've seen articles, whether it was in the Globe and Mail or whatnot, that there has been this misconception. So hopefully we can provide some answers to really change those misconceptions that are out there.
I would add to that and tell you that our COVID positive patients who are symptomatic, we're actually not doing home births, but we're recommending a hospital birth. So this idea that you should be at home is not true. And the other part is that public health is really good at following clients who are positive. So they will call them and follow up with masks and anything they need.
So Rick, why don't we actually switch gears a little bit and talk about that? Because a common theme that we've seen that in articles, we've seen that in the media. During COVID-19 pandemic, should I switch from a hospital birth to a home birth? Should I switch from an obstetrician to a midwife so that I can have a home birth? Is that safer? And I'm hoping we can kind of chat about that a little bit. So what are your thoughts?
Yeah, so firstly, I want to say that the task force from the province, and we don't necessarily say that just because you're COVID positive, you have to deliver in the hospital. That might be what you're doing in your practice, and it's a reasonable thing to do. But many patients who are COVID positive are fine, and they're healthy, and they're not ill. And as long as the midwifery group have sufficient PPE and the situation at home can manage that, then we don't regard COVID being COVID positive as a mandatory hospital, at least from the provincial point of view. So I don't think that necessarily means that everybody should go and have a baby at home. I think having a home birth is a particular focus philosophy, which has got a very well tried and proven place in obstetric care. And people who want to go and have a home birth because of that philosophy of care should do so. I don't think it's a reason to switch care unless they were particularly of that philosophical, because there are different risks and benefits for it. And I think that's up to each person to make an assessment for, independent of whether you're COVID positive or not. Whether you're COVID positive or not shouldn't make a difference. Some people think that it's safer because people don't want to come to the hospital because it's COVID. I've always pointed out to my patients who don't want to come to the hospital, it's probably the safest place in the city to come and be there, because at the hospital you're screened, you're masked, everybody is very careful because everybody is so focused. And I always say I'd rather go to work at the hospital than go shopping at Sobeys, where I don't know if everybody is as careful, and I don't know what people's symptoms are, and there's no screening at the door. So I don't think hospitals are a dangerous place to go to. So the decision between a hospital and a home birth care, I think it relates to the general principles of where you want to have your baby, and that COVID is really should not be a factor in that decision.
Where you want to have a baby, but also if you're a candidate for a home birth. You need to be a proper candidate for a home birth, regardless of COVID. And I think, Rivki, you probably can speak to this a little bit.
So when I said COVID positive, I think I said symptomatic COVID positive. We're encouraging not to have babies at home. It's not that we wouldn't do a home birth for those kind of clients, but we're encouraging them not to. I totally agree, Dr. Barrett. I think that the decision to have a hospital or home birth is a decision regardless of COVID, in the same way that I believe that about your healthcare provider. I think most women, before they get pregnant or when they get pregnant, think carefully about who's the best healthcare provider for them. And so switching when you've decided, for example, an OB is the best for you at this stage, I think it takes a lot of thinking about why you're actually doing that, especially if you have a healthcare provider that you have a trusting relationship with, that you're happy with. In terms of home birth, different clinics are doing different things. So we have a birth room in our clinic, which we can clean and sterilize and clean properly. We don't know, one of the things that we talk to clients about is transfer time during this time. So calling an ambulance, how available paramedics are, how long it's going to take for the paramedics to get to you if you need to be transferred to the hospital. We don't know about exposure to clients or ourselves in home versus a hospital. We don't have enough data on that, whether there's an increased risk to us or to the clients at home. We also talk about self-isolating before having a home birth to protect themselves, minimizing people in the home, cleaning the home, how you would do that. So it's a bit of a process. And like I said, different clinics are choosing to do different things depending on the availability of their PP and their comfort level around going into people's homes.
Thanks, Rivki. And I think one of the misconceptions is that people think if they have a home birth, they might be allowed to have more support people in the room. Can you speak a little bit about that? And sorry if that's a little bit...
No, so it's really clinic specific. Like, we are asking people to limit the support person. Are we saying, at North York, it's one support person per patient? Are we saying one support person per patient? Probably not. We're not saying that. But would I want to come and see, 10 people and your neighbors and everybody else at your home birth? No, I don't at this point want to see that. We're also screening people before we go into their homes. So we're doing a phone screening on the phone to see if people have symptoms. We do have PP. We don't have a huge amount of N95 masks in our clinic. So that's where if someone's symptomatic and known COVID positive, why we're kind of encouraging them to go to the hospital. There's also an SOGC guideline about continuous monitoring with COVID positive patients, and we can't do that at home. So that's also part of that discussion.
Yeah, so the SOGC directive for continuous monitoring is not something which the Toronto group recommended or the task force. It makes no sense, to be honest, and I'm on the board of the SOGC, so we can all disagree, and reviewed all the guidelines. So it makes, as we've said, the virus, it's only dangerous for your baby if your mom's sick. And if you're not sick, then there's no reason to continue monitor the baby. So I think that's not a reason. That's certainly not a reason to be at home. I think it's quite fine to be at home as long as you're not sick. And if you're sick, then you need to be in hospital, as you've quite often said. In terms of the support people, there are a couple of reasons why hospitals limited, and why some midwifery groups have also limited, because it's simply the amount of PPE. When I shared with you that we're short of PPE, we are short of PPE. We just haven't got enough to give to support people, because then we wouldn't have enough to support. So that's one of the reasons. The other reason is there have been several hospital outbreaks now of COVID and healthcare workers. There's a recent one I was reading tonight, Toronto West, 79 healthcare workers are infected. Children's in Ottawa Hospital, children's were affected by visitors coming into affected. I can go on and on. And so, hospitals are just concerned that they haven't got the ability to monitor a lot of people around the hospitals, which is why we've reduced visitors, not because we want to reduce visitors. It's simply a factor of, do we have enough PPE for ourselves? And the answer is we don't, at least in the hospital. And I've heard many midwifery practices. 2 weeks ago was our group, they just didn't have enough. And the secondly is the concern that visitors will come into the hospital and result in these hospital outbreaks, which are devastating.
So we are also short of PPE, and which is for clinic, we're asking people to come by themselves unless they've had a cesarean and need help to carry their babies for that reason.
So speaking about support people, one of the questions that have come in the group chat is, what is the current policy on number of support people allowed to accompany women giving birth? And I can speak to that. I work at St. Michael's Hospital, and I know that this is generally the policy across the board. Most of the hospitals are allowing one support person during labor, and that's if the mom and the support person screens negative for COVID-19. If they screen negative, they can come in. You're allowed one support person. So if you have a doula, it's the doula or your partner, right? So it's one support person as long as mom and support person screen negative. Any other comments about that?
The question that came in also sort of asked about self-isolating after being home after the hospital, on the assumption that somebody is not symptomatic for COVID and just came and in a healthy circumstance had their baby and went home. I'm not informing patients that they need to isolate in any way differently because they were exposed to the hospital setting. The question though about who comes and sees you at home, grandparents and things like that, as tough as it is, in my opinion, having a baby doesn't make it any different than all the general recommendations that are being made. If you don't live under the same roof with people, and I realize that, in caring for small children at home while you're in hospital for a delivery, there may have to be some safe, sort of small exceptions or very unique plans. I had a patient who intentionally came to the hospital and had her baby alone a couple of weeks ago, despite, she was not symptomatic for anything, but her partner stayed home with their child. They made that decision together. So people are definitely, sort of making challenging decisions, but I don't think having a baby is an exception, unfortunately, to the very sensible public health recommendations. And it would only be as those recommendations are lifted for all of us across, sort of general city, provincial, country, society, that I would encourage people to lift them for themselves and their families.
And I think that's a really good answer. I think the issue that we have is that to make blanket statements, black or white, no, you cannot have this person come help you. We don't know, mom's situation. We don't know if there's potentially abuse in the home. We don't know their situation. Maybe they need that extra person to support them. We just don't know. So to have a blanket statement saying, no, you cannot have an extra person come in, we can't do that. But at the same time, we all need to be practicing physical distancing. And I think one of the questions that has come up, especially in the postpartum period, is if my parents or the grandparents self-isolate for 2 weeks, can we then have them come in to support us? You know, that's a very common question. How would any of our panelists answer that?
Rachel?
You know, I mean, I think that, again, Tully, I think I agree with you completely that there's no, you know, single answer that suits everybody, and it might be what suits the circumstances. I mean, in general, I think you're the bubble of people who live together. I have certainly heard of families where, for example, maybe somebody completely self-isolates, and then maybe you come, you know, mom comes and actually moves in and lives with you for the foreseeable future. And I realize that people have to make their circumstances reasonable. You might be recovering from a cesarean with a partner who's working outside the home, and suddenly you don't have your daycare or your nanny, and you can't lift your toddler, like, you know, or as, you know, exactly as you said, maybe home isn't a safe environment, or maybe somebody's a single parent to multiple children recovering. So I think that there are a lot of unique circumstances, and I think you have to do what is safest in the environment. To the best extent possible, I would maintain isolated family units together and not try to create loopholes and exceptions where they shouldn't exist.
Yeah.
Yeah, I think that's the right answer. I mean, we must realize we're dealing with a really scary time for pregnant women and their partners. But that category, as we said, is probably least at risk. The ones that are most at risk are the parents and grandparents. And we just have to always keep that, as hard as it is. Those are the ones we have to keep safe and isolated, as hard as it is for, you know, a family bringing home a new baby. That's the most logical place to get help and advice is the grandparents. But that might not be the safest advice for them.
Yeah, and not just for the newborn, but really also for the grandparents as well, because we know that people over the age of 65, 70 are at higher risk of having health consequences, serious health consequences of COVID-19. So it's both families, but really more so for the grandparents that want to come help and support. And we know it's a really tough time. It's not what anyone would have ever imagined. But I think what Dr. Spitzer was saying is making decisions that really limit the most amount of risk, and whatever that is in your situation, right? And so people need to make that individual decision that really limits the most amount of risk.
You know, and what I try to tell people also, and I know John remembers, we worked together through SARS 17 years ago at Women's when I was in training. You know, as gut-wrenching as it is, and as difficult a time it is for families and grandparents who want nothing more than to come together at these very special moments, we are at least, you know, very far ahead of where we were 17 years ago, that people can connect virtually, that you can see a baby, you know, sort of over a screen. I know it's not the same, but it's a lot better than we had the last time we were facing some of these similar issues.
Yeah. And I think people had the same questions, not just for grandparents, but hiring extra help to come into the home, be it night nurses. So people have relied on night nurses or extra help in the home. What do they do in those sort of situations? And I think the same thing you would answer, the same thing would apply.
Yes, for sure.
Yeah.
You know, some people are fortunate also, again, everybody's circumstance is unique, but some people may have their partner home more than they were otherwise. And so, you know, some of those arrangements of bringing somebody else into the home because the partner's going out more often may be less relevant. Other times it's more relevant. It's hard to say.
Rivki, any suggestions, any advice when it comes to the postpartum period and support people?
I'm really just saying the same thing as you guys are saying to people. Like, if you can limit your contact with people, that's the best, but everybody has to do what works for them.
Okay, great. Okay, so let's switch gears a little bit. So we talked about vertical transmission, impacts to the mom and baby. We spoke about support people in labor. Can we talk a little bit about prenatal care? So some questions have come in. How has prenatal care changed? And, you know, should a pregnant patient buy their own blood pressure machine?
So I'd like to take that. So at the hospital, we had to make way for an expected wave of sick people. And we wanted to decrease the risk of transmission by having less people in the hospitals because we had to preserve that facility. So we looked at all the different ways and thought amongst ourselves and came up with a protocol which relies on virtual care for some visits, for engaging the patient in things like taking her own blood pressure in between visits, and really critically looking at the kind of visits we do and how often we need to see people in a low-risk pregnancy. The high-risk pregnancies, you haven't got much choice. You carry on and do those. And it's really been in every cloud there's a silver lining. And for me, the ability to sit back and critically look at what we do with prenatal care and think about, do we really need to do that? And can we do it in a better way has been a really, a light bulb has gone off in my practice. And I don't think I'm going to have trouble going back to what it was. I find the virtual visits engaging. My patients like it. I actually find myself spending more time because I'm doing it at a time when I'm not rushed in a busy clinic with lots of prenatals waiting. So I'm actually spending more time with sort of the first visits. I often see the patient for the first time in her situation and her family with the kids there. It's really quite nice and engaging. The number of visits are decreased. I won't tell the exact schedule. But when we think about it, the way we schedule and do prenatal care and what we do is a hangover for the last 200 years. In most of it, we don't test urine anymore. Measuring symphysis or fundal height, how big your tummy is what we do. But really with a few, if there's availability, a few timed well ultrasounds, maybe you don't need to rely on this frequent visiting of tummy measurements because it's got other resource implications as well. Not everybody can do this depending on ultrasounds. But I believe and patients really like not having to take a half day of work, spending all this time and expense. The parking expenses at hospitals is horrendous. And I don't believe care is going to be affected. I really don't. What we are doing right now is actually writing a research grant with colleagues of mine to see if we can not go back and then compare the two outcomes, both economically and outcomes. I can tell you right now who the patients are going to choose. And you know what? We're living in a different era. There are integrated devices for blood pressure, for even oxygen saturation, for even fetal movements, something which moms can wear and send the signal Bluetooth back to the obstetrician. So this has really given us an opportunity to think about what we're doing and I think move prenatal care into the next century. I'm starting now group prenatal classes on Zoom for my patients. And it's actually wonderful. Everyone sits around a Zoom. People can be anonymous if you want. And everybody asks the same questions because they're the same questions about prenatal care. And everyone hears the other woman speaking about their backache or pain in this. And oh, I've got that too. It's a remarkable new learning, which I'm quite excited about.
Sorry, go ahead, Dr. Spitzer.
Sure, I was just going to second those comments. I think that whenever this new reality comes to something of a conclusion, there are many, many things that are not going to go back to being the same. I think workplaces, non-medical workplaces are not going to be the same. I think work travel is not going to be the same because of all that we've learned that we can do virtually. And I agree wholeheartedly with John. Group prenatal care is an example of something that is really more sort of education-based that's quite well suited to the virtual environment and is actually, as I said at the beginning, I'm interested in underserved populations, has actually shown very nice benefit from the group camaraderie in underserved populations, both, sort of across our continent and across other continents as well, and in low and middle income settings. And I think that there's a lot of great things that can be done that sort of make up the time and education that we spend with our patients, and that probably some of those metrics can be taken on a lesser basis, which is exactly the same thing that we're doing as well. And there are, sort of guidelines and recommendations at this time of what is the appropriate reduced frequency of visits compared to previous.
Yeah, that's great. That's excellent. And in terms of blood pressure machines, you could potentially go to your local pharmacy if Shoppers still has a blood pressure machine. I know certain Shoppers have stopped. You can measure your blood pressure that way. And when we call you for a virtual visit, we're actually going to ask you for signs and symptoms of high blood pressure, including a headache, visual changes, right upper quadrant, abdominal pain. And so if there were any of those symptoms, we would then direct you what to do next. And then in terms of not listening to the baby's heartbeat in an in-person prenatal visit, we're actually going to ask you to tell us about fetal movements, because that could sort of be a surrogate model sort of for fetal viability in lieu of that sort of Doppler that we would use in person in a prenatal visit. And other things we'll be asking you in a virtual visit, but I agree, it's been a lovely sort of opportunity to stop and reflect and think about how we're delivering care. So it'll be interesting to see how this moves forward post COVID-19.
I've been thinking about something, and I think I want to go back to the PPE question, because I think it was asked by in the dental situation, and I probably shouldn't have answered that, because I'm so focused about the hospital and stuff. The true answer to what the dentist, and maybe I want to go back there a little bit because I don't want to leave the wrong impression. I don't know what's aerolizing in a dental office. And I've just finished writing the task force for obstetrics and gynecology. I know a lot about what happens in obstetrics, but the question I think we have to ask ourselves, and I don't know this because I'm not a dentist, but is a drill aerolizing? If the drill is actually an aerolizing AGMP, then maybe everybody has to wear 95s. So I want to go back to that question because I probably should have thought a little bit more about answering it, because it just struck me that there's a drilling, a dentist drill, right? And I don't know, Rachel, I don't know if you know if a drill is an AGMP or not. If it is an AGMP, then not only the dentist, but the patient will probably have to wear a 95. And so I don't know the answer. We'll have to wait for another panel. Maybe you should do another panel with some expert dentists on. So I just wanted to clarify that. I'm pretty sure I know what the hospital is AGMP, but I'm not sure in a dental office. I just want to go back and say that.
And I think the bottom line is, if it is an aerosolizing procedure, that's when an N95 mask is indicated.
Correct.
Otherwise, a surgical mask is indicated.
100%. That's the same. That's print. But the point I didn't think of is, what about the drill? I don't know what that does.
It does produce aerosols, somebody said.
Somebody says the use of a dental drill does produce aerosols. So there's a difference, and I've learned this. There's a difference between producing aerosols, right, and aerolizing the virus. So this is a really important question, I think we have to know, and you have to, somebody's saying, I believe dental does aerolize.
Okay. Well, we're getting into very specifics over here.
I just wanted to call, because the question specifically from the dentist was, what do I do for my patients? And I kind of said, well, don't worry about it, wear a droplet. Yes. That might not be true. So wait till you get an expert dentist on and I can tell you.
Yes, and feel free to reach out and we can probably collaborate with an expert dentist and find out the answers for you. I would think the nitrous oxide machine used in the dental office is aerosolizing. Well, that actually is a good question. Let's talk about that, because one of the questions that has come in is, how has pain management changed while in labor in the hospital? And nitrous oxide is one of the things that has changed, and we could speak about that a little bit. And I know I've heard Dr. Barrett talk about the evidence behind that and why we've sort of removed nitrous oxide from the floor on labor and delivery, as well as birthing centers. And the other thing that's changed a little bit is the recommendation towards epidurals and why. So let's speak about that a little bit, pain management in labor.
Yes, so firstly, we should not have any change of policy, I don't believe, towards epidural. Epidural is a choice that people make for pain reliever, and I don't think people should be forced into having one when they shouldn't. And being COVID positive or suspect is not an indication of necessity to have epidural. It's got really nothing, I don't believe, to do with it. The problem is, if we take away nitrous oxide, people might not have anything else, because there aren't very many other good effective pain reliefs, and nitrous oxide is useful for patients, and we used to use it a lot. The trouble is, and I don't know the dental office, I'm not going to dental office again, but at least in the labor floor, in a woman in labor who is using nitrous oxide and is breathing and expelling forcibly on that mask, without a two-way valve in that, which has got a special kind of valve, which they don't have, it might be an AGMP. We don't know. So we kind of said that it's probably not recommended. I don't think anyone's proven which way it is, but that was the general recommendation. Again, not on great evidence, but
there's not a great evidence, and I think people were trying to make policies to be, safe and overcautious and sort of remove nitrous oxide, and I think the evidence probably is still yet to come.
Kelly, if you're talking about differences in regional anesthesia, so epidurals and such, I think the only thing that people may be referring to, because I agree with John, there's no difference, but I think sometimes people are trying, if and where possible, to avoid emergencies on the labor ward and to less run into situations where somebody might end up with a general anesthetic for a cesarean section. So if there are urgencies that can be a bit better anticipated to perhaps encourage the presence of an epidural so that that could be topped up in an emergency and used, as opposed to suddenly ending up in a general anesthetic with an aerosol generating procedure. I think people are just trying to be a little bit more thoughtful, planning, and cautious where it's possible.
You know, it's interesting because with our pandemic pregnancy guide on Instagram, we're getting a lot of questions from internationally and across Canada. And people have commented that at their hospitals, they're sort of encouraging or enforcing a mandatory sort of epidural. So that's where these questions are actually coming from. So it's really good. It's not something that's happening in our hospitals. We are not doing that. There are many ways to control pain effectively in labor. And I know Rifki could probably speak about that as well, because I'm sure a lot of her patients don't have epidurals and can manage pain quite well. So that is not a policy in place that is effective in hospitals.
I'm going to have to sign off. I've got another teleconference coming out, so I apologize I have to leave it early, but I'm sure that Rachel knows.
Expertise in the area, so thank you very much.
That's a pleasure.
Thanks, Jonathan.
Bye-bye.
Okay. Do we have any time for any more questions? Hurry up.
I just wanted to maybe, there was a comment about sort of precautions in labor that I'm sure is of interest to people. And I was just going to say, like, I don't think that there's, if somebody is without symptoms, they're going to be screened when they come to the hospital. I don't think that there are any particular precautions that they need to take in labor. I sort of also say, once you're in your own room, for a woman who's potentially in pain or labor or pushing, while you might be sort of wearing a mask out in, you know, sort of lobby areas of the hospital, or when you go grocery shopping, I'm not recommending to my patients that they, as the patient who we are all masking ourselves to protect, needs to be masked during labor. I could imagine that that could be quite uncomfortable with heavier breathing, with pushing and things like that. So I don't think there's any precautions. The only other thing that I'm telling people, and it depends very much on the environment in which you're delivering, but sometimes our food establishments and things in the hospital are the opportunity to leave and, you know, get some nourishment and things like that. So you might want to bring a little bit extra with you because it may be a little bit harder to acquire some of those snacks or nourishments when you're in.
So that's excellent. There was a couple of questions that we haven't been able to address, and obviously there's very limited time to this webinar, but I just want to direct you to our pandemic pregnancy guide, because we answer a lot of these questions. So there was one question we weren't able to answer about what to pack for the hospital. We have that all in there. We have how has prenatal care changed? Are patients wearing masks in labor? So all of that is there. Packing for labor and delivery, we have a great list that has actually been provided by our followers, but also we use lists that have actually come out from Sunnybrook and Sinai and St. Michael's Hospital. So I think the big things to remember for support person when you're admitted in labor is that definitely bring lots of food, because you're going to be limited in terms of in and out privileges, and bring chargers, bring your technology so that you can connect with your loved ones that are outside of the hospital. So those are some big things. So a lot of your questions, feel free to send them our way. Would be happy to answer them through this virtual platform. And I think really the main point of something like this is so we can provide reliable medical information, because there's a lot of misinformation out there, and to allow for this, for a virtual community to gather. And especially within our own community here in the Jewish community, it's really wonderful to be able to meet and come together and to answer some of the questions during this time of uncertainty. So I'm sorry we're not able to answer all of these questions. I know there's a question about circumcision, and you know what, I'd be really happy to answer any of these questions offline. I can give you my email, or you can send some questions to the pandemic pregnancy guide Instagram account. But we're gonna just change direction just for a few moments here to end our webinar. And I'm gonna introduce Dr. Bev Young, who is a psychiatrist out of Mount Sinai Hospital, whose focus is actually on perinatal mental health. And this week is actually the perinatal mental health week. So it's actually quite appropriate that she's coming on to chat with us about perinatal mental health, especially during COVID-19. So Dr. Bev Young, if you want to introduce yourself again and just share some thoughts during this time.
Hi, first of all, thank you so much to UJA for including me in this talk. I think that we focus a lot on the physical aspects of delivering and not always on the mental health aspects. So tomorrow actually is World Maternal Mental Health Day. So I was hoping to advocate for good mental health in pregnancy and the postpartum period. The one thing I want to tell all the pregnant women out there is this is happening. You are having a baby, no matter where, how, with whom, you are having a baby. This baby is coming out of you. And you might not have control over how this happens. You might have a list of how you want it to, or a birth plan, and that might not come to fruition, but this baby is coming out. So my first recommendation is to control the controllables. And you only have so much control. And unfortunately, in this case, especially, sometimes you just gotta let go and just give in and lean in to the anxiety and just try as much as possible to be in the moment in your delivery. I also wanted to talk a bit about, we talk a lot about worries, and there was a study that came out recently that over 50% of Canadians have worsened mental health during this time. And that's really understandable, but I think that a lot of people have worries versus anxiety. And I really want to differentiate what's worries and what's anxiety. When we talk about worries, obviously we're all worried. We're worried about catching, we're worried about giving it to our parents, to the elderly, we're worried about our babies. These are all normal worries. When it becomes an anxiety, though, is when the worries become out of control and you start ruminating and feeling overwhelmed and panicky. Sometimes that's accompanied with physical symptoms. And the anxiety also has to interfere with your functioning. So if you find that you're not able to calm down, you're not able to sleep, your relationships are affected, your work is affected, you're having trouble sleeping and functioning during the day, that's when it becomes more of a concern. So I am a very strong proponent for healthy mental health and well-being in pregnancy and postpartum. There's a couple of things I do want to mention. We happen to be running a group at Mount Sinai now called Pregnant and Afraid. Unfortunately, right now it's just for the Mount Sinai patients, but I do want to let you know it runs every Wednesday. And it's run by me and an obstetrician. So we go through all the obstetrical issues in pregnancy at Sinai, and then I talk about mental health issues. If you want more information, you can get my email through UJA. And the final thing I want to say, and I think this is really important, is that when you go home and you're alone with your baby and your partner, there's a sense of calm. So I actually think it's okay, and I'm sorry to the bubbies and zadies, but I actually think it's okay that you have this sense of, this is our family now, and this is the most important thing. And there really is this sense of calm, and it's all about us, and it's all about the baby, and we don't have to worry about running out to shop and buy things and entertain and clean the house. And I want to leave you with that level of positivity so that you can actually enjoy the postpartum period and don't have to worry about it so much.
Thank you, Dr. Young. That was extremely helpful. There was actually a study that came out that potentially the birth weight of the baby at day 5 is higher at day 5 than it was pre-COVID-19. And maybe that's just the ability to focus on breastfeeding and be together as a family. So there's some silver lining in all of this too, although I know it's extremely challenging for families and not being able to introduce their new baby to their loved ones and grandparents, and especially for the grandparents too. So thank you for that. Okay, great. So we're going to just wrap up. And last but not least, I want to introduce Melissa Muscat, who's the chair of the Women's Philanthropy for UJA's 2020 annual campaign. So hi, Melissa Muscat, if you want to end off.
Hello. Hello. Thank you so much, Dr. Vogler. As you heard, my name is Melissa Muscat, and I'm the chair of Women's Philanthropy for the 2020 annual campaign. Firstly, I want to thank our incredible panel this evening, Dr. Vogler, who was also our moderator, Rivki Meldung, Dr. Barrett, and Dr. Spitzer, and of course, Dr. Young for her very important input on mental health. You are all fabulous, and I thank you on behalf of the whole virtual community out there, Thank you so much for taking the time out of your incredible busy schedules to join us. I'm sure you're double duty, not only in your professions, but in your family lives as well. So thank you so much. We greatly appreciate all that you do in the health sector and for our community. I also want to thank all of you, our participants, for attending tonight's webinar. I hope you have found this to be insightful and engaging. I know I did. As Sarah mentioned earlier this evening, it's really important for me to reiterate how important UJA is at this critical time. The needs of our community are greater than ever due to the pandemic's impact. And UJA is focused on ensuring our community comes out of this pandemic as whole as possible. If you are in a position to make a gift today to UJA, I encourage you to do so. UJA is a crucial part of our community, and ensuring its success now is ensuring our community's future. A link has been provided in the chat window section of the webinar. If you would like to make a donation, if you have any questions or need to reach out for help in any way whatsoever, please reach out to Jennifer Apple. Her email has also been provided in the chat, in the window for the chat. Now, normally I would wish you a very safe drive home, but I know you don't have far to go. So thank you so much for attending and have a wonderful evening.